Hello everyone. Today we will examine somatic symptom and related disorder. The lecture will focus on four major types within this category. We will begin by clarifying the basic concept of what is meant by somatic symptoms and then turn to the following four disorders in sequence. Somatic symptom disorder, conversion disorder, illness anxiety disorder, factitious disorder. For each disorder, we will consider its core features, possible causes, and clinical implications in order to broaden our understanding. The term somatic symptom literally refers to a symptom that manifests in the body. The mind and body are closely interconnected, and psychological stress or anxiety may sometimes be expressed in the form of physical pain or discomfort. For instance, a person may experience headaches or abdominal pain when feeling tense. In DSM-4, these conditions were classified under somatoform disorders, which include somatization disorder, pain disorder, and hypochondriasis. However, because the boundaries between these diagnoses were often overlapping and unclear, DSM-5 reorganized the category as somatic symptom and related disorder. In this group, psychological factors play a significant role in the presentation of physical symptoms, yet medical examinations often fall into identify a clear organic cause. The revised DSM-5 include four principal disorders in this category. We will now consider each of these in turn. We will now consider the most representative disorder within this category, namely somatic symptom disorder. Let us begin by examining its main characteristics. First, patients tend to exaggerate their physical symptoms or become excessively preoccupied with them, which leads to significant impairment daily functioning. Second, the symptoms are often vague or nonspecific. For example, they may involve abdominal pain or fatigue. Even when no clear medical explanation can be identified, the symptoms are nonetheless experienced as severe and distressing by the patient. What is essential to emphasize is that even if objective findings are absent, the suffering itself is real. Third, these symptoms may influence interpersonal relationships. At times, they can function, often unconsciously, as a way of drawing attention or exerting control over others. Another noteworthy feature is what is often referred to as doctor shopping, meaning that patients frequently visit multiple hospitals or clinics in search of repetitive consultations. There are also gender differences. Somatic symptom disorder is more common in women. In children, it frequently manifests as abdominal pain, headaches, fatigue, or nausea. In summary, somatic symptom disorder should not be dismissed as malingering or exaggeration. It has a serious clinical significance because it causes genuine impairment in the individual's life. Somatic symptom disorder does not arise from a single cause, but rather from the interplay of multiple factors. These may be grouped into personality trait, demographic factors, psychological and social factors, and biological factors. With respect to personality trait, individuals who display high levels of anxiety, neuroticism, and heightened sensitivity to stress are at greater risk. Such individuals often interpret normal bodily sensation as threatening. As a demographic perspective, the disorder is more common among women and older adults. It is also more prevalent among individuals with lower educational attainment, those who are unemployed, and those of lower socioeconomic status. Psychological and social factors are equally important. Experiences of abuse or trauma in childhood increase vulnerability, and cultural and familial reinforcement, such as receiving extra care or attention when ill, can perpetuate symptoms. Furthermore, individuals who have underdeveloped coping strategies are more likely to rely on physical symptoms as a way of dealing with stress. Biological factors may also play a role. Dysregulation of neural circuit involved in pain perception has been suggested, and there may also be a genetic predisposition towards somatization. In short, somatic symptom disorder is best understood as a multi-dimensional condition arising from the combined influence of psychological, social, and biological factors. The treatment of somatic symptom disorder is challenging as there is no single universal effective intervention. Nonetheless, several approaches have been found to provide benefit. Psychotherapy, particularly cognitive behavioral therapy, is one of the most effective strategies. CBT helps patients identify and modify distorted patterns of thinking related to their symptoms. Psychoeducation is also important, enabling patients to understand the relationship between psychological factors and physical symptoms. Regular consultation with a trusted physician can reduce unnecessary anxiety by providing consistent monitoring of symptoms. It is also necessary to encourage patients to become aware of and express repressed conflict or negative emotions. Treatment does not simply aim to eliminate symptoms, but to understand the underlying psychological meaning that the symptoms may convey. The role of family is critical. Families must provide support while avoiding behaviors that reinforce symptoms. For instance, exempting patient from all responsibilities or providing excessive reward in response to symptoms may inadvertently enrich the disorder. Therefore, effective care requires balanced cooperation between patient, the family, and healthcare providers, with the shared goal of providing consistent and constructive support. The next disorder we will consider is convergent disorder, which in DSM-5 is more recently referred to as functional neurological symptom disorder. The core characteristics of convergent disorder can be summarized as follows. First, the symptoms typically involve motor or sensory symptoms. Examples include paralysis, seizures, or loss of vision or hearing. Second, the symptoms often do not conform to known patterns of neurological disease. In many cases, medical examinations fail to identify any underlying organic cause. Third, the onset of symptoms is frequently associated with a situation of psychological stress. Major conflicts or traumatic experiences often precede the appearance of symptoms. Fourth, it is important to emphasize that these symptoms are not intentionally produced. In other words, they are not fabricated, nor are they the result of conscious manipulation as factitious disorder or malingering. Finally, some patients with convergent disorder exhibit what has been called la vela defiance, a striking indifference to their symptoms. Even when facing serious impairment, such individuals may respond with unexpected calmness or detachment, a feature that can provide important clinical clue. Let us now turn to the causes and risk factors associated with convergent disorder. From a historical perspective, this condition was once referred to as hysteria. The term has its origin in ancient Greece, where it was mistakenly believed to result from problem of the uterus. In the late 19th century, Sigmund Freud reinterpreted hysteria, proposing that its symptoms represented the conversion of unconscious conflict into physical manifestation. It was within this context that the concept of conversion first emerged. Freud suggested that unresolved unconscious sexual conflict, such as the Electra complex, could be transformed into physical symptoms if left unaddressed. Although Freud's explanation is no longer widely accepted, many scholars continue to recognize the association conversion disorder with early life adversity. From psychoanalytic perspective, the disorder is understood as the result of effort to defend against unconscious conflict or intolerable emotions. Rather than allowing such a conflict to reach consciousness, they are expressed through physical symptoms. This substitution provides what is termed primary gain. By expressing internal conflict through bodily symptoms, the individual avoids confronting it directly. At the same time, the resulting impairment may allow the patient to avoid duties or responsibilities, thereby providing a secondary gain. From behavioral perspective, conversion symptoms are seen as yielding practical advantages. Physical symptoms can serve to escape stressful circumstances or elicit attention and support from others. This is similar to psychoanalytic notion of secondary gain, but with the key distinction. While psychoanalysis view secondary gain as a consequence of symptom development, the behavioral perspective regards it as a primary cause. Finally, from a cognitive perspective, symptoms may serve as a means of communication. When individuals have difficulty expressing emotion verbally. In this view, physical symptoms function as a kind of language of distress. For example, someone unable to articulate anger may instead express it through paralysis. Although this shares some similarities with the psychodynamic account, the cognitive perspective emphasizes that such symptoms are not primarily a defense against anxiety, but rather a familiar and accessible way of expressing negative emotions such as anger, anxiety, or jealousy. We will now consider the treatment and intervention strategies for conversion disorder. The primary focus of treatment is the reduction of anxiety, which may be linked to either to past traumatic experiences or to the distress caused by current physical symptoms. Thus, the fundamental aim is to lower the individual's levels of anxiety through approaches such as insight-oriented therapy, exposure-based intervention, or pharmacological treatment. From a psychodynamic perspective, the goal is to help the patient recognize and address underlying intrapsychic conflicts, thereby reducing the need to convert this conflict into physical symptoms. In other words, the therapeutic task is to make it unnecessary for anxiety to be expressed somatically. From a behavioral standpoint, the emphasis is placed on addressing the factors that maintain the symptoms. For instance, if seizures occur as a way of avoiding certain situations, gradual exposure to those situations is implemented, while simultaneously training the patient to manage stress through direct coping strategies rather than through physical symptoms. Biological intervention may also be considered. Anxiolytics or antidepressant can be prescribed to assist with the regulation of anxiety, although medication serves as an adjunctive measure rather than a definitive solution to the symptoms themselves. Finally, the principle of reinforcement must be taken into account. When patients derive rewards from occupying the sick role, their symptoms are likely to be maintained. For this reason, both families and clinicians should avoid or provide excessive reinforcement to illness behaviors and should instead encourage and positively reinforce healthy adaptive behaviors. Now we turn to illness anxiety disorder. The defining feature of illness anxiety disorder can be summarized as follows. First, individuals are preoccupied with the idea that they have or will soon develop a serious illness. Importantly, there are no prominent physical symptoms present, or if symptoms do occur, they are mild in nature. Second, despite repeated medical examinations and reassurance from physicians, their anxiety persists and often intensifies rather than diminishes. Third, although the age of onset varies, it frequently begins in early adolescence. Fourth, the disorder tends to be chronic and relapsing. Symptoms often subside temporarily, only to return with renewed intensity. Finally, because of its persistence and rigidity, illness anxiety disorder may appear similar to a personality trait. However, it goes far beyond ordinary health concern, exerting long-term and pervasive effect on the individual's daily functioning and quality of life. We shall now examine the causes and risk factors associated with illness anxiety disorder. To begin, stressful life events or minor health threats can serve as powerful trigger for excessive worry. For instance, a trivial bodily change may be interpreted as a sign of a severe illness. Second, childhood experiences such as abuse, serious illness during early development can heighten an individual's vulnerability to anxiety in adulthood. From a behavioral perspective, illness anxiety can also be understood as the result of a learning process, such as classical conditioning or modeling. This is, children may observe excessive anxiety responses to illness in their environment, or they may learn to associate illness with heightened fear or distress. Finally, from a cognitive standpoint, two tendencies are central: hypersensitivity to bodily sensation and the misinterpretation of minor symptoms as evidence of serious disease. A common example is perceiving an ordinary headache as a sense of a brain tumor. Let us now turn to the treatment and intervention strategies for illness anxiety disorder. From a behavioral standpoint, exposure with response prevention is often employed. Patients are gradually exposed to situations that provoke anxiety while simultaneously being discouraged from engaging in avoidant response. This process helps to diminish excessive anxiety over time. Cognitive therapy, on the other hand, focuses on identifying irrational beliefs and maladaptive assumptions and replacing them with more realistic and adaptive interpretations. In particular, treatment emphasizes correcting the tendency to misinterpret benign bodily sensations as indicators of serious illness and reducing the patterns of excessive attention to such sensations. Cognitive behavioral therapy, which integrates these approaches, is widely regarded as one of the most effective methods for helping patients to understand and manage their health-related anxieties. The final topic we shall address is factitious disorder. Factitious disorder is also known as Münchhausen syndrome. Individuals with this disorder deliberately fabricate or induce physical or psychological symptoms in themselves or sometimes in others with the intention of receiving medical attention or treatment. Their behavior typically fall into several categories. First, they may falsify symptoms or manipulate medical records, such as fabricating test results or altering documentations. Second, in some cases, they inflict actual injury upon themselves or even upon another person in order to simulate illness. Third, they may report false events. For example, claiming that a spouse has died when in fact this is untrue. Diagnosis of factitious disorder cannot rest solely on assumptions regarding patient motivation. It requires objective evidence that symptoms have been fabricated or intentionally induced. It is also important to distinguish factitious disorder from malingering. Malingering involves deliberate deception for external reward, such as financial gain or legal advantages. By contrast, the central feature of factitious disorder is the desire to assume the sick role itself rather than to obtain tangible external benefits. Prevalence is difficult to determine precisely, but research suggests that it may occur in approximately 1% of hospitalized patients. It often begins in early adulthood, and individuals may frequently move from hospital to hospital, or develop conflicts with medical staffs. Parents sometimes referred to as hospital shopping. Factitious disorder is observed more frequently in certain groups. For example, individuals long-standing medical histories from childhood, those who harbor resentment toward the medical system, or those employed in health-related professions such as nursing or medical assisting are disproportionately represented. It is also believed to be associated with childhood trauma, neglect, dysfunctional caregiving environment. Nevertheless, the precise causes and effective treatment for this disorder remain unclear. As such, clinical management requires particularly careful and cautious judgment. Another form of factitious disorder is Münchhausen syndrome by proxy. In this condition, the individual does not fabricate or induce symptoms in themselves, but rather in a dependent person, such as a child, an elderly family members, even a pet, in order to gain attention and sympathy in the role of caregiver. Typical behavior include dramatic exaggeration of symptoms and medical history, falsification of medical records, and in many cases, possessing intensive knowledge of medical procedures, which often bring them into conflict with healthcare professionals. Remarkably, the perpetrator is often the biological mother. For instance, in one case in the United States, a mother administered sodium to her 5-year-old son, leading to his death. She was subsequently diagnosed with Münchhausen syndrome by proxy. This condition must therefore be regarded not only as psychiatric disorder, but also as a form of child abuse. Its covert and persistent occurrence within family underscores its seriousness. Accordingly, clinicians must take into account both the psychopathological aspect and the imperative of child protection. Accurate diagnosis and effective intervention require careful evaluation and multidisciplinary approach. Today, we have examined the category of somatic symptom and related disorders. We have reviewed the features, causes, and clinical interventions associated with the 4 subtypes. Noting the subtle distinctions that exist among them, these differences are especially important to keep in mind. This concludes our lecture. Thank you for your attention.